Welcome to Healthcare du Jour, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring you insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. Now here's your host, Matt Fisher.
Welcome back, and thank you for joining as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On the menu today is Alli Oakes, Chief Research Officer at Trilliant Health. Alli, welcome to the show.
Hi, Matt. Thanks so much for having me.
So, Alli, what I always like to do before getting into the main part of the conversation is to give my guests a chance to provide more of an introduction in terms of who they are and what they do. So, Alli, the floor is yours.
Thanks, Matt. Well, as you said, my name is Alli Oakes, Chief Research Officer at Trilliant Health. In terms of what I do, I love healthcare data and slicing and dicing it in all different sorts of ways to understand the sort of macro trends that are going on in the health economy.
So, Alli, before kind of starting to figure out what some of those trends are that are happening within healthcare, the other kind of background question I always like to ask is, what got you into healthcare in the first place?
Yeah, it's a good question. Something I love about healthcare, and I feel like public health specifically, is people often take all sorts of winding roads to find their niche within it. It's such a big space. In terms of how I found my way here, I always knew I was really interested in health and healthcare. And when you're younger, I feel like that usually means you think you'll become a doctor or a physician. So for a while, I thought that and was a psychology major in undergrad. But after that, worked for a couple of years at the NIH doing clinical research. And it was while doing that job, both working with patients, but also working with data, that I realized I was really interested in the data component and trying to understand healthcare at more of a systems level. I also got really interested in sort of the decision making that different physicians were making and seeing different kids coming in on sometimes evidence-based or non-evidence-based, medication sorts of situations. And those sorts of interests led me to find this whole world of health services research and health economics, which I really fell in love with. So that was what I decided to pursue. Did a PhD in health services research at Hopkins. After that, did a postdoc at Penn Medicine in the Penn Medicine Nudge Unit, sort of focused on behavioral economics, trying to figure out how we can improve decision-making within our healthcare system. After that, worked at Anthem, so seeing the payer side of things. And then finally came over to Trilliant Health around 3.5 years ago. At Trilliant, we just have access to such interesting and sort of all-encompassing data. And the sort of work we do and our motivations in doing the work was hard to turn down. And that's where I find myself today.
So kind of with all that background and, as you mentioned, looking at the data on an ongoing basis, what are some of the bigger trends that you're starting to see emerge that might be different from what had previously happened in healthcare or are, kind of expansions and continuations of the past?
Yeah, so every year we put out our big annual Trend Shaping the Health Economy report, and we just released our 5th iteration of it this past October. And I think sort of 4 of the major things that we're paying attention to this year: 1, value and affordability. It's been an issue in our healthcare system for a long time, but it really feels like it's something that's starting to be at a breaking point. 54% of Americans say that the healthcare system is in a state of crisis. So it's something we're really watching very closely. From a value point of view, we spend a lot of money and don't get a lot out of our system. So that's something we're watching very closely. Sort of number 2, I would say, our issue with neglecting the fundamentals. So in our country, we really incentivize specialty care intervention instead of primary care prevention. We have a much smaller primary care workforce in the US than compared to peer nations. And unfortunately, we think this is an issue of you get what you pay for. We just don't incentivize and reimburse primary care in this country. So that's something we're watching. Third, of course, the issue of fraud, waste, and abuse. So there's always chatter about how much of US healthcare spending is wasteful. It's a hard number to pin down, but undoubtedly we have to acknowledge there's a lot of waste in our system. So that's an issue where we're doing measurement in different studies. And then fourth, I would highlight what's going on as it relates to different care settings. So we're seeing this transition to alternative care settings and the outpatient setting. And we really think that's something that's accelerating. And that's a topic we can get into a little bit more later on.
Yeah, so I mean, those are certainly very interesting trends, and I suspect they all interweave. Just thinking about the first couple that you mentioned of value and affordability and neglecting fundamentals. So even as you were starting to talk about it, it sounds like there's a lot of overlap and kind of interaction between what you're probably gleaning from those trends.
Yeah, absolutely. So we know there's this longstanding value issue in our country. We spend 17.6% of our GDP on healthcare, and we have really poor results. So in the US, life expectancy is around 78, which is 3 to 8 years younger than other peer nations. We also spend a lot less time in good health. We spend more time in poor health. So, healthy life expectancy in the US is around 64, while it's greater than 70 in most of those peer countries. So, we have to sort of take a step back and ask ourselves what we're doing. And that certainly relates to the primary care and prevention point of view. But as it relates to affordability, there's been this sort of big test with cost shifting and cost sharing over the last decade and making patients have this idea of, skin in the game and that would reduce our healthcare spending. So between 2010 and 2024, we've seen premiums increase by 86%. At the same time, we've seen deductibles increase by more than 50%. So people are really starting to feel the true cost of our healthcare system. And again, the value that we're getting out of it, as is measured by health of our population, we're just not seeing things pay off.
Yeah, and kind of picking up as you were talking about the cost shifting and the increasing cost share that individuals are picking up, you know, that seems like it then ties directly into the affordability because I think as you implied or you mentioned, the outcomes are not good, but the cost of it keeps increasing, and if we're shifting that over to individuals, what is kind of the cascade effect that you're seeing from the data on that front?
Yeah, so unfortunately, it seems like people are interacting with the healthcare system less. So, over the last decade or so, we generally see sort of flat to declining utilization despite our population growing. There's also an issue of sort of mistrust baked into all of that. People go to a doctor's office and they get a shockingly expensive bill afterward. After that happens enough times, people become really skeptical of our healthcare system and it erodes at trust within the healthcare system. That's something we've sort of known for a long time, but something that's new in this space and somewhere where we're investing a lot of our time is in the health plan price transparency data. So this is data that was released in 2022 as a result of an executive order from the first Trump administration. And the health plan, sorry, it's a little bit of a mouthful. The health plan price transparency data, which I'll call HPPT from now on, that data actually allows us to understand for a given procedure rendered by a particular provider at a particular location and reimbursed by a specific payer, what is the negotiated rate for that service? So we've invested a lot of time and effort in downloading all of that data from the different payers, cleaning it to make it usable. And based on that data, we see that there are just these unexplainable variations in negotiated commercial rates that exist. So just for a handful of DRGs, inpatient procedures, we see that across the country, the same procedure varies by more than 8x. And even when you get down to the same hospital and two different payers, so maybe United Healthcare or Aetna, we see that those two different payers reimburse the same provider and same hospital very different amounts of money. So when we talk about affordability, it seems like we really have a price issue in this country rather than a utilization problem.
So kind of given the exposure of that data and the insights that you're starting to be able to glean from it, with you giving one of those great examples, are you starting to see any shift in the discourse or probably hopefully any shift in actions being taken since you really need the action as opposed to just people talking about it?
Totally. So that's what we're hoping for and sort of the alarm bell that we're trying to ring for people. We think the health plan price transparency data is a little bit different from price transparency initiatives in the past in a couple of ways. One, over the last sort of decade, a lot related to price transparency has put the onus on patients and sort of expected patients to shop for their care and shop us out of this problem. But I think, history and evidence suggests that patients aren't going to be the ones to fix this problem for us, nor do I think we should expect them to be, honestly. So something that the health plan price transparency data does, which is different, is it really puts the onus on employers to be taking this data seriously. It also implicates their fiduciary duty. So with our sort of employer-sponsored insurance set up in the US, employers provide insurance for something like 54% of the American population. Those employers have a fiduciary duty to be providing high value health benefits to their employees. Historically, though, employers haven't really been able to understand the value of a health plan because they haven't known or had information on what these negotiated rates are. And like put very simply, a market that has proprietary prices is doomed to fail. Like no other industry works that way. So we think the sort of advent of the availability of this data will start to move the needle because employers, who again are insuring more than half of our population, have to care about this data and have to figure out how to start using it.
Yeah, no, I think that's a good point. It's similar to topics that I've covered in previous episodes, where as you're talking about, the employers have a fiduciary duty, and now that the plan members could have a hook to be able to bring a claim against their employer
Mm-hmm.
if they're not exercising prudent discretion over the use of the funds. So there's kind of that growing field of potential liability, and for better or worse, when liability can attach to something, all of a sudden you'll start to see a change in behavior because no one
Mm-hmm.
wants to be on the receiving end of a lawsuit.
Correct. And this is where you, as a lawyer, certainly know more than I do. But right, we're now starting to see these lawsuits come where different employee groups are saying, hey, you, as our employer, aren't appropriately looking out for us and bringing us benefits that are, providing us high value. This needs to change. And we're starting to see those suits come and sort of play out in the courts.
Yeah, and kind of picking up on that point and maybe pivoting slightly, it's
Mhm.
as you just said, if it's someone bringing a suit, it's probably to some degree premised on the pricing, but then I think that I suspect kind of translates into one of the other trends you mentioned of having neglected the fundamentals.
Mhm.
Because if you focused on the building blocks of preventative care, or the looking at who's going to have the most interaction with individuals, that can I guess theoretically at least, and I'm not sure how much what the data or evidence would show, but that could then lead to reduced need to spend in other areas
Mhm.
because you're catching issues earlier or you're preventing them altogether.
Yeah, so we really sort of have a history of incentivizing specialty care intervention, which is more expensive, instead of primary care prevention, which of course also involves a lot of important lifestyle related behaviors and choices that people are making too. But in the US, we have fewer primary care physicians. People also use less primary care than in peer nations. Sort of looking at our provider workforce, only around 12% of physicians practice primary care, whereas in other peer nations, it's something like 25 to 50% of the workforce. And if you ask ourselves, well, how did we end up here? Unfortunately, I think it's an issue where you get what you pay for. Our primary care providers, in terms of how they're compensated, they make about half of what many specialists do. In terms of how our fee for service system is set up with RVUs, procedure based specialties are much more valued than, getting in the trenches and that sort of primary care work, or even things like social work and connecting patients to care and services. They just aren't things that we've made a priority. And I think that sort of explains where we've landed in terms of the health of the American public and the ways at which it seems to be eroding. So, if we want to start to change the tide on that, I think we probably need to take a hard look at how we incentivize primary care and incentivize prevention rather than a reliance on intervention or pharmaceuticals, and figure out how to sort of change the narrative on that.
Yeah, I think those are all great points. And for those of you just joining, I'm talking with Alli Oakes from Trilliant Health, talking about different emerging trends that Alli's seeing within healthcare. And kind of picking up on the last point that you're making, Alli, around I think it sounds like really trying to fundamentally shift behaviors, not just of the healthcare system, where you need to invest more, as you're saying, in primary care and getting out in front of issues, but also the incentives around what care is delivered to patients and kind of what options are available. you know, how do you see that potentially aligning or being influenced by potential goals of the administration and a lot of what's becoming the discourse around changing what's in food, or just the broader discussion around um, you know, not just relying on medical interventions as you were talking about.
Yeah, unfortunately, in a lot of ways, our healthcare system is definitely set up to be reactive to sort of what people show up in the office with. So I do think this sort of renewed emphasis on chronic conditions and this idea of, making America healthy again, it is an important thing for us to be focused on within healthcare. So as it relates to those chronic conditions and sort of the increase that we've seen in them, we are seeing an increase in our younger 18 to 44-year-old working population, which is something we're paying a lot of attention to. So just looking at mortality rates within that population, we see that the rate for things like chronic liver disease, nephritis, chronic lower respiratory disease, and diabetes, the mortality rate for all of those things are getting worse, unfortunately. In our data, we also see this constellation of what we're sort of calling emerging chronic conditions. So it's not your traditional things like diabetes, but things like sleep apnea, thyroid dysfunction, endometriosis, migraine, chronic fatigue. It's just this constellation of conditions that suggests the American public is just sort of unwell. So those are things that we're tracking very closely. And in terms of how we start to turn the tide on those things, one, I do think sort of increased attention related to those conditions is important. But rather than jumping to sort of the first line of treatment as being something pharmaceutical or people taking a medication, I do think it's important to consider what are possible lifestyle modifications that could be made or sort of behavioral modifications that could be made that are very low cost while sometimes challenging to implement, but could potentially really improve health of individuals and at the population level.
Yeah, no, and I think that's a great point because it's, as you're saying, if you focus on non-pharmaceutical or kind of traditional medical interventions and go into picking up on the lifestyle change piece, that can end up having a cascading effect because if you use those changes to help address maybe one or two identified chronic conditions and improve health overall, that's going to help reduce the likelihood of other chronic conditions arising and just produce better overall well-being.
Totally. It's a multiplier effect. And behavioral health is something else to layer on top of that. For the first time in our data, we saw that there were more behavioral health related visits than primary care visits in the last year. And sort of related to what you're talking about, a multiplier effect. If sort of the same patient, if you will, like, say a 50-year-old guy who has diabetes and maybe hypertension, and then another individual, 50-year-old man who has diabetes, hypertension, and depression, that individual with depression, if it isn't well managed, they're likely to have much higher healthcare costs in general. Their hypertension and diabetes are likely to be less well managed. So another thing that we should definitely be paying close attention to is our sort of investment and prioritization of behavioral health and the way that impacts healthcare spending and utilization and wellness more broadly too.
It really seems to bear emphasizing that point you just made of, I think you said behavioral health visits were higher than primary care visits, which is a pretty significant milestone, I suspect. And, from the data, have you been able to determine what might be driving that or, what is encouraging that increased utilization to occur?
Yeah, well, I think there's two things to sort of tease apart when you see an increase of some kind, whether it's chronic conditions or behavioral health. There's a question of, well, is this increasing need because for the first time ever, more people have whatever this condition is? Or is it better access and the same number of people have this issue, but more people are able to get treatment for it? I think as it relates to behavioral health, it's probably a little bit of both. So one, we know that there's sort of a behavioral health crisis in this country. Mental and behavioral health seem to get a lot worse sort of during and post-COVID. And I think a lot of that is still being figured out. So that is a problem that we need to be addressing. Second, though, I do think there's also been better access in the years post-COVID, partly as it relates to a lot of direct to consumer or telehealth based behavioral health companies and sort of therapy platforms that popped up during COVID. So I think the behavioral health issue is one, a worsening problem. But on the brighter side, I do also think there's increased access, which we would consider to be a good thing. And then as it relates to sort of eclipsing primary care volume, that was focused in the commercially insured population. I think it's important to think about how people interact with behavioral health care rather than primary care. You know, if you're really getting treatment for something as it relates to behavioral or mental health, maybe you're going once a week for a period of months. Maybe you're going every other week for a year. So you would expect people getting that care to use it more than you would primary care. But just as a general trend, like you were saying, we thought it was something interesting and worth flagging.
Yeah, no, and that's a fair point, as you said, where you might have more intensive periods of
Mm-hmm.
interaction as you're, maybe initiating treatment or addressing what could potentially be an acute need or other
Mm-hmm.
condition, and then maybe it starts to normalize. But I also want to pick up on one of the other pieces you talked about in there, where it's I think you were mentioning there one of the factors can be increased access, which can include virtual care, which is, I think, while the data has shown that behavioral health and mental health have seen the biggest sustained spikes,
Mm-hmm.
with that access, or that information on that front, does that end up feeding into the other trend one of the other trends we were talking about of potential waste and abuse, where maybe not that all that access isn't equal, and
Mm-hmm.
by equal I mean maybe not all the same quality.
Yeah, absolutely. So, with the COVID-19 pandemic and sort of the proliferation of telehealth based medicine, I think there's a really important question as it relates to increased access, and is the quality of all of it the same? And we've sort of been tracking that and watching that shake out over the past 5 years. Telehealth has definitely sort of had staying power within the mental and behavioral health space. I think we see something like 60% or maybe even almost 70% of all telehealth visits at this point in time are for mental and behavioral health. So that's an area where it does seem like it's a really good substitute. But another area where we're sort of watching and paying a lot of attention is the role of direct to consumer prescribers. So these are your companies like Amazon Clinic and their RX Pass, Nurx, GoodRx, Cerebral. Now you even have your pharmaceutical companies getting directly into the space with things like NovoCare and Lilly Direct. So these stakeholders are influencing more of the prescription patient journey. And sort of taking a step back, we think this has the potential to be disrupting traditional patient provider relationships in a way that may not be such a good thing. And that these different direct to consumer platforms could potentially be increasing fragmentation and duplication sort of across the system. So, as it relates to what we were saying about primary care before, the question is, who's the quarterback for these patients? Like, who knows what's going on with their entire care journey? And as more of these sort of direct to consumer point of service companies pop up, I think that fragmentation is probably only increasing. And while maybe increasing access in some ways has the potential to maybe be harming quality in others.
Yeah, and kind of emphasizing fragmentation there also gets to other evergreen issues across healthcare. Of part of the reason you have fragmentation is because different systems have difficulty interacting with each other
Mm-hmm.
for arguably business reasons on the back end of the different platforms that might be getting utilized.
Mm-hmm.
Um, but it's kind of seeing that potential growing fragmentation. Are there any undercurrents that you've seen that would suggest that there's the system is trying to fight back against that, or find other ways to help ensure that we're not just going to be creating new silos after have been trying to spend so much time breaking
Yeah.
them down?
Yeah, I think it's a good question. I think it's probably an example of one of those things where the pendulum sort of always swings. So I think on the heels of COVID, with all the telehealth based care, we saw the pendulum swing way to one side of the equation where, patients were potentially getting care for different things through these cobbled together different online platforms. are consumers or patients really enjoying that process? I think it's hard to say. But as sort of overall telehealth utilization has decreased by a lot, over half, maybe even closer to 70 or 80%, I think it's clear that overall patients prefer an in-person care experience, maybe carving behavioral and mental health out of that as its own separate thing. But looking at our data, we do see that in 2024, the vast majority of patients are getting the majority of their care via in-person interactions. I think it's something like 20% of people receive hybrid care, so meaning they're doing a little bit of both. Very few patients are receiving completely telehealth-based care at this point in time.
Yeah, no, and kind of piecing or parsing apart that information is definitely important. Alli, believe it or not, we're already almost out of time. So I'm going to close with a final question for you, which is, looking ahead to when you do, I think what you will end up being the sixth annual report, what do you think might be one of the trends that you identify when you get to the end of 2026?
Yeah, so a big thing we've been beating the drum on and continue to think is really important is the concept of value for money. I think over the last decade, we've had this great experiment with value-based care. And as a health services researcher, it was something I was really excited about too. But I think the evidence at this point suggests that it's just not the thing that's going to save our healthcare system. So we really think that we're sort of at a breaking point or crossroads as a result of the combination of things we talked about today. So it's either market discipline, where us as a healthcare industry need to start competing on negotiated rates and quality and start providing value to patients and value to the country, or structural reform from the outside is likely to come our way, either from, state governments or the federal government. And that would likely show up in the form of price caps. And a couple of other things that contribute to that we're watching very closely are the removal of the IPO list, which again will accelerate that migration to the outpatient setting. The team model, which is a mandatory model coming out of CMMI, which essentially extends the DRG to a 30-day period. And then we're also sort of tracking this concept of focus factories. Historically, hospitals have had to sort of be everything to everyone. And we're now wondering if hospitals start to pare down the number of services they provide and instead focus on the things that they're really good at and can provide at high value to the patients within their market.
Yeah, well, it'd certainly be a lot to keep an eye on. And, as I said, believe it or not, we are already out of time. So I want to thank my guest, Alli Oakes, for a great conversation today.
Thank you, Matt. Thanks for having me.
And thank you to everyone listening. Keep the dialogue going and connect with me at #HCDEJURE. I'm Matt Fisher. Until next time.